Hello everyone, I am Dr. Sutapa Roy and the topic for discussion today is abnormal uterine bleeding or AUB. Now definition wise, the abnormality in one of the following menstrual variable in a woman of a reproductive age group, the variables being frequency. Now frequency means how often or frequently the menstrual cycle occurs. It may be 25 days, 30 days or 40 days even, and how regularly this occurs is the next variable, that is regularity. If it is of 35 days, then it should occur regularly every 35 days given plus minus 2 days. Then the duration of the flow. The duration of the flow can last from 2 to 8 days. And the fourth variable is the perceived volume of bleeding. The important word here is perceived. It is completely subjective. It is the woman's perception of the flow by which we grade it as heavy, she grades it rather as heavy or a normal flow. For a lady, particular lady, even if she soaks 3 to 4 pads per day, for her it may be normal, while for another lady this could signify a heavy bleeding. Now, before proceeding further, we have to rule out pregnancy and its complications completely. Now, a lady who is used to having a menstrual flow every say 5 to 6 weeks and now she is overdue, 5 to 6 weeks have gone by and she starts bleeding. She will assume it to be her normal menstrual flow, but in this case she could be pregnant and this bleeding may signify that she either has a missed abortion or a threatened abortion, right. So, pregnancy or any of its complications have to be ruled out for us to label the woman as having AUB. Now, previously the nomenclature was FUH or functional uterine bleeding. Now, functional uterine bleeding, we had to rule out all the other causes of abnormal uterine bleeding and then only we could label her as FUH. Now, the word functional is a positive word and what we want to denote is abnormal bleeding. So, this was changed to DUB, dysfunctional uterine bleeding. Dysfunctional uterine bleeding but was a terminology that was used to denote abnormal bleeding during the perimenopause. Now, to differentiate abnormal, we have to know what is normal menstrual bleeding. Now, regularity, as we have already seen, these cycles have to be regular in a normal menstrual bleeding. The cycles could last from anywhere between 21 days to 35 days and the duration of the bleeding could be anywhere between 2 to 8 days. The average amount of flow would be from 35 to 50 ml, the lowest limit being 5 and the maximum being 80 ml. Now, this 80 ml, how we arrive at this figure is if a lady keeps on bleeding month after month more than 80 ml, then she will land up with anemia and with the complications of anemia. Hence, this limit, upper limit has been set at 80 ml. Now, the earlier terminologies, metrorrhagia, that is irregular menses, menorrhagia, increased amount of flow or increased duration of flow, oligomenorrhea, the cycle length is more than 35 days. So, it could be called a delayed, a prolonged or an infrequent cycles. Polymenorrhea, the cycle length is less than 21 days. So, it is a short cycle or a frequently occurring menstrual cycle. Hypomenorrhea, the amount of blood loss is reduced. Now, the newer terminologies. Frequency, anything less than 24 days is frequent, anything more than 38 days is infrequent. Regularity, here normal variation from the shortest to the longest cycle in a particular lady, maximum would be between 7 to 9 days. Slight variation also depends on the age. Duration of the menstrual flow. Now, only two categories are there. Normal is less than 8 days or equal to 8 days and prolonged more than 8 days. The volume. Now, HMB or heavy menstrual bleeding is that amount of bleeding which is sufficient to interfere with the woman's quality of life. So, it is again I am reiterating that it is the woman's perception, it is completely subjective whether she has a heavy bleeding or it is a normal flow. Now, intermenstrual bleeding, spontaneous bleeding occurring between menstrual periods and it could be either cyclic or random. Now, this is the classification accepted by FIGO since 2011. There are two sets, one is the structural causes or the PALM, the polyp, adenomyosis, leiomyoma and M stands for malignancy and hyperplasia. These are the structural causes. The non-structural causes are the Cohen group. Here C is for coagulopathy, O is for ovulatory dysfunction, E is the endometrial causes, I is the iatrogenic causes and under N anything that is not otherwise classified. So, this is the classification of AUB accepted by the FIGO. Now, AUBP or polyp. Now, this polyp could be either cervical or endometrial. These are usually estrogen dependent. Nowadays, as breast cancer survivors are increasing in number, there may be quite a few patients on the drug tamoxifen. Now, these patients are also likely to have AUB because of presence of polyps. Now, the types of bleeding in AUBP or the patients who have polyps, it could be intermenstrual bleeding or it could be a heavy menstrual bleeding or the bleeding may be completely irregular. Now, we will see how the endometrial polyp or the cervical polyp grows. This is the uterus, this is the cervix, this is the uterine cavity. Now, if the polyp is single, this is its peduncle and this is the polyp. Now, this polyp, its most dependent part, this may necrose and then that could give rise to the intermenstrual bleeding, right. So, the lady could have spotting because of the presence of a single polyp or the polyp could be an endocervical polyp. So, this is the endocervical polyp. Same thing here, if necrosis occurs, then there will be bleeding, abnormal bleeding and the patient will come to the gynecologist with the complication, with the complaint of AUB, right. Or there could be multiple small polyps which are not pedunculated like this, and in this case what happens is, since the surface area of the intracavitary endometrium increases, therefore, the bleeding surface also increases and this will lead to HMB or heavy menstrual bleeding. So, if there is a single polyp, the type of bleeding will be different. If there are multiple polyps, then the type of bleeding will be different. Now, for the diagnosis of polyps. A simple plain ultrasonography or ultrasound or a TVS would even be better. TVS is transvaginal sonography, that this is sufficient for us for the diagnosis of polyps. If they are not very clearly visible, then saline infusion sonography can be taken the help of. Here what happens is we instill saline in the intracavitary space, the space gets distended and the polyps are very clearly delineated. If we happen to have hysteroscopy with us, then that is the best tool, because that would be diagnostic as well as therapeutic. With the help of the hysteroscope, we can see inside the cavity completely, locate the polyp, and under vision we can resect it out. This specimen then is sent for histopathologic examination and we get a 100% confirmatory diagnosis, right. Now, AUBA or adenomyosis. The lady typically is in her late 30s or in her 40s and she will present with the complaints of secondary dysmenorrhea with HMB, that is heavy menstrual bleeding. Now, secondary dysmenorrhea is that the lady has never had dysmenorrhea since her menarche. All of a sudden in her mid 30s or late 30s or even in her 40s, she has dysmenorrhea along with the heavy menstrual bleeding. That is known as secondary dysmenorrhea. On examination, the uterus will be bulky, it could be tender, and ultrasonography is diagnostic. The ultrasound features of a patient with adenomyosis is typically the loss of the endomyometrial junction. Now, this is more common with the posterior myometrial junction, endomyometrial junction, because adenomyosis more commonly occurs in the posterior uterine wall, or you could have small islands of endometrium which is surrounded by myometrium, and this gives the classic salt and pepper appearance on ultrasonography. Now, usually there is asymmetrical myometrial thickening. Now, Venetian blind appearance or fan shaped shadowing, these are other ultrasonographic features in a case of adenomyosis. MRI, though more specific, but it is never the first line imaging technique that is resorted to, as it is costlier and not much additional information is gleaned. We skip this slide, we will come back to it later. Now, AUBL is leiomyoma and the symptoms will depend on the location, size and the number of leiomyomas or fibroids as we commonly call them. Now, the fibroids mostly cause heavy menstrual bleeding, or if there is a fibroid polyp, then that can cause intermenstrual bleeding also. Sometimes one or two fibroids may be completely an incidental finding. The lady having AUB will have some other cause for the bleeding and the presence of the fibroids may be purely incidental. She may or may not have dysmenorrhea. Now, we go back to the earlier slide and we see the different sites that a fibroid can be located in. Now, this number 0 is the fibroid is completely intracavitary and it has a peduncle. So, this is a fibroid polyp. We have already seen what polyps are, and this is a fibroid polyp, unlike the endometrial polyps that we have seen before. Now, number 1, here the fibroid is mainly intracavitary. More than 50% is intracavitary and slight amount less than 50% is intramyometrial or intramural. Number 2, less than 50% is intracavitary and more than 50% is intramural. All these three, 0, 1 and 2 could be responsible for AUB and heavy menstrual bleeding also. Number 3 is completely intramural, but it is just touching the endometrium. This is unlikely to cause AUB. Number 4 is completely in the myometrium, and this is unlikely to cause abnormal bleeding until and unless these 3 and 4 are quite a few in number, so that the uterus becomes bulky, and that is going to increase the surface area of the endometrium, and then they are likely to cause heavy menstrual bleeding. Number 5, more than 50% is intramural and less amount is subserosal. So, this is unlikely to cause AUB. Number 6, more than 50% is subserosal and less than 50% is intramyometrial, while number 7 is completely subserosal and it is hanging by a short stalk. We can see that, and this is least likely to cause AUB, or in other words, it is unlikely to cause heavy menstrual bleeding or any other form of abnormal uterine bleeding. Number 8 is the cervical fibroid. Okay. Now, AUBL patients, on examination there will be an enlarged uterus. The uterus usually is irregular because it may be studded by the fibroids. It will have a firm feeling and the uterus will not be felt separately. Like for example, if there is an abdominal mass, then and it is ovarian, here one will be able to feel the uterus, it can be felt completely separately from the mass. But in case of a large fibroid uterus, we will not be able to feel the uterus separately, as the uterus itself has grown large and become bulky. So far as the investigations are concerned, ultrasonography is sufficient to tell us the number and the locations of the leiomyomas. Hysteroscopy is a good tool for submucous fibroid. As we have seen, the submucous fibroid is completely intracavitary, and by a hysteroscope we can see it and under vision resect it out and then send it for histopathology examination. Now, hysteroscopy is not all that difficult because we can make use of the office hysteroscope nowadays, and without taking the patient to the OT administering anesthesia, we can see the intracavitary structures. AUBM or malignancy. Now, malignancy and hyperplasia could be cervical or endometrial. Now, in cervical malignancy, we will get a specific bleeding pattern, that is intermenstrual, especially it is typically postcoital. The patient will come to the gynecologist with the complaints of postcoital bleeding. It could be either a frank malignant growth or a tubercular ulcer that is present on the cervix. Management wise, removal of the growth or taking a small biopsy piece from the growth if it is large, and removal of the tubercular ulcer if it is small enough, or again biopsy from the edge of the ulcer and sending it for histopathological examination will give us a 100% confirmatory diagnosis. Now, AUBM endometrial, this could either be frank malignancy or hyperplasia. For both of these, the reason basically is unopposed estrogen exposure. Now, in increasing age, perimenopausal age, because of continuous and ovulatory cycles, the estrogen levels are high and continuous. In patients of prolonged history of anovulatory cycles, example PCOS patients, that is polycystic ovarian syndrome patients, and in the tamoxifen users also, we could get frank malignancy or hyperplasia of the endometrium. The diagnosis is again by ultrasonography, but endometrial biopsy is confirmatory. Now, the types of endometrial hyperplasia. Simple hyperplasia, only 1% of it will be converted to frank malignancy. In complex hyperplasia, the rate goes slightly up. It is 3% of conversion from hyperplasia to malignancy. In simple hyperplasia with atypia, it is 80%, and in complex hyperplasia with atypia, it is 29%. So, if we come to know that a particular patient has complex hyperplasia with atypia, then we are alerted that this patient could go in for a frankly malignant endometrial carcinoma, and we can treat the patient accordingly. Now, this endometrial hyperplasia is because of unopposed estrogen exposure. This happens, as we have seen, in increasing age because the cycles are mostly anovulatory in those cases. Now, continuous anovulatory cycles, patients of PCOS and tamoxifen users, these are usually the patients who will go in for endometrial hyperplasia. The diagnosis is by endometrial sampling taken in the OPD itself and endometrial biopsy, both of these sent for histopathologic examination, and we get a confirmatory report. Now, hysteroscopy is best in this condition because we can see completely the intracavitary area, and from the most suspicious areas we can take the endometrial biopsy, as this is more likely to give a better result. Now, this completes the palm section or the structural section of the FIGO classification. Now, we come down to the Cohen part of it or the non-structural part. AUBC, C for coagulopathy. The heavy menstrual bleeding in about 13 to 20% of women of reproductive age group come under the subset of AUBC. Now, puberty menorrhagia is the most common presentation of patients of AUBC, and 1/3 of all the cases of puberty menorrhagia, 1/3 of them are under AUBC. If there is a family history of say von Willebrand disease or any other coagulopathy, then one can direct one's efforts towards evaluating the patient for AUBC and treating her accordingly. Now, ITP or immune thrombocytopenic purpura is another disease where another coagulopathy rather, where the patients can present with heavy menstrual bleeding. Now, history of heavy menstrual bleeding is there since menarche in these patients of AUBC. There could be history of bleeding in small dental procedures. There could be history of bleeding during surgery, history of bruising, history of epistaxis and history of gum bleeding. Now, if family history of bleeding disorders is present, then we can concentrate on that and treat the patient of puberty menorrhagia accordingly. Now, there could be a presentation could be also a failure to respond to conventional treatment. The girl with puberty menorrhagia may not have directly come to the gynecologist. She might have approached the general physician or the GP or her family physician, and they might have tried to treat her with some conventional non-hormonal treatments, and she has not responded to that. So, she could come to the gynecologist with the complaints of heavy menstrual bleeding even say 1 or 2 years after her onset of menarche. Now, these patients of puberty menorrhagia, they will give a history of heavy menstrual bleeding since menarche. There could be history of bleeding during minor dental procedures, there could be history of excessive bleeding during surgery, history of bruising, history of epistaxis, history of bleeding from the gums, and if there is a family history of bleeding disorders, then we can direct our attention of evaluating the patient accordingly and treating the patient for that particular coagulopathy. Now, the patient could also come to us with a history of failure to respond to conventional treatment. This may be even 1 or 2 years after her attainment of menarche. Initially, because of her heavy periods, she may have gone to the general practitioner or approached her family physician, who would have tried to treat her with non-hormonal conventional treatment, and this will of course fail, and the patient would not respond to it and finally land up with the gynecologist. We have to find out the particular coagulopathy that the girl is suffering from and then treat her accordingly. Now, AUBO or ovulatory dysfunction. Here the bleeding pattern is usually heavy menstrual bleeding, but it could be irregular cycles at random bleeding completely, or it may be delayed cycles followed by heavy and prolonged bleeding. Now, this type of bleeding is usually estrogen withdrawal bleeding. Now, we can find this in both the spectrums of both the ends of the spectrum, in the adolescents as well as in the perimenopausal age group, because in both these patients, the ends of the spectrum, the ovulation will not occur, and therefore, these cycles are anovulatory and the bleeding is estrogen withdrawal bleeding. Now, I have mentioned estrogen withdrawal bleeding. Now, we will see what the normal menstrual cycle is, right. Now, suppose this is day 1. Here estrogen is being secreted, small follicles, they grow, they become large, secrete estrogen, and one dominant follicle is formed. Now, this dominant follicle roughly around day 14, it is going to rupture, ovulate and release the ovum. Okay. Now, then after this, this is going to form the corpus luteum. Now, this corpus luteum secretes progesterone. Therefore, progesterone comes into the circulation, the progesterone is being secreted. Now, this corpus luteum will undergo atresia, then there will be a fall in the progesterone level, and then the menses start. So, normal menses are progesterone withdrawal, progesterone withdrawal. Now what happens in anovulatory cycles is these follicles keep growing, but there is no dominant follicle. No dominant follicle, so no ovulation, no ovulation, no corpus luteum formation, so no progesterone. It is only estrogen that is there in circulation, and then estrogen, once estrogen is secreted, there is only in the endometrial cavity this estrogen is being secreted, and this keeps on thickening. So, here layer upon layer of endometrium keeps forming till finally it outgrows the blood supply. Now, these thick endometrium is formed because of the action of estrogen, till finally the blood supply which comes from the basal layer, the endometrium outgrows this blood supply. And here these follicles that were there, they also start becoming atretic. Therefore, the estrogen level starts dropping and there is estrogen withdrawal bleeding. So, in anovulatory cycles it is estrogen withdrawal bleeding, right. Now, all this thick endometrium is shed during the menses, and therefore, the bleeding in estrogen withdrawal cycles is always heavy, unlike the progesterone withdrawal cycle in normal menstrual phase. Now, we see the causes of chronic anovulation. Obesity is one cause. Now, because in obesity, in the fat layers, aromatase is present, which converts the testosterone into estrogen, and therefore, there is a high level of estrogen circulating. Now, in androgen excess states like in PCOS, there is chronic anovulation, and therefore, there is only estrogen withdrawal bleeding. Now, in thyroid disorders, especially hypothyroidism, there is HMB. While in hyperthyroidism also, in the initial stages, there could be heavy menstrual bleeding. In hyperprolactinemia, there is reduced secretion of GnRH, and this affects the HPO axis and leads to anovulation. In chronic illnesses, like suppose a chronic liver disease, liver is the site where coagulation factors are synthesized. Now, if there is liver disease, the coagulation factors are synthesized to a lesser extent, and therefore, there is some sort of coagulopathy and the patient has heavy bleeding. Now, this coagulopathy, actually we could label this patient as belonging to the subset AUBC for some time at least, right. And the liver also is a site for production of other type of proteins, SHBG, the sex hormone binding globulins. Now, sex hormone binding globulins bind the estrogen and testosterone that is free. Now, if there is less amount of SHBG, then the bound form of these sex hormones will be less and the free form will be more, and that is what is going to lead to. Now, we look at the causes of chronic anovulation. Obesity is one cause. Now, the fat in obese people, it has aromatase, and this is responsible for the conversion of testosterone to estrogen. Therefore, there is a high level of estrogen which causes anovulation. In androgen excess states like in PCOS patients also we find anovulation. Thyroid disorders, especially the hypothyroid cases, will also have anovulation. There could be some anovulation or AUB in the hyperthyroid state also, but that is only in the initial part of it. Now, some chronic illnesses could also lead to chronic anovulation. Suppose a chronic liver disease, we take that as an example. Liver is the site for synthesis of coagulation factors. Now, if the coagulation factors are not synthesized properly, then the patient will have heavy menstrual bleeding because of lack of coagulation factors, but then that we will place into the AUB-C subset. Now, the liver is the site for synthesis of other type of proteins also, like SHBG or sex hormone binding globulin. Now, SHBG binds the sex hormones and therefore, there is less amount free, but if the sex hormone binding globulins are less in amount, less amount of this hormones will be in the bound form and more of it will be in the free form. That is another reason that causes anovulation. So, this is how chronic illness or rather say chronic liver diseases will cause anovulation. Now, excessive exercise, eating disorders or stress, all these affect the HPO axis and therefore lead to chronic anovulation. Now, metropathia hemorrhagica, this is a typical type of AUB. It is an anovulatory AUB. It occurs in females between the ages of 40 to 45 years, and symptom wise the lady will have 6 to 8 weeks of amenorrhea. She could also have more than 8 weeks of amenorrhea, which is followed by painless vaginal bleeding. Sometimes this may also happen at the start of her menses itself. The absence of pain is typical in these ladies. On examination, the uterus will be bulky, but there will not be any tenderness. Pathologically, there is mild myohyperplasia and uniform enlargement of the uterus. The endometrium is thick, polypoidal with multiple small polyps protruding into the cavity. And as we have seen, when multiple polyps protrude into the cavity, the surface area of the endometrium is increased and that leads to heavy bleeding. Histopathologically, there are signs of cystic glandular hyperplasia or the Swiss cheese pattern. There is complete absence of the secretory endometrium. The ovaries may have a few cysts, but there is definitely no corpus luteum. Therefore, no progesterone and only estrogen withdrawal bleeding occurs. Now, this is typically ovulatory bleeding. These are two types of ovulatory bleeding. The irregular ripening, here there is deficient corpus luteum function. The corpus luteum forms, but it is not able to produce the amount of progesterone that is required to the threshold level. So, even before the patient begins her menses, there is spotting for a few days, say 8 to 9 days prior to the onset of her menses, and then finally the menses start. So, that is irregular ripening of the endometrium. Now, irregular shedding, here the persistence of the corpus luteal function creates the problem. As the corpus luteum keeps functioning even after the onset of menses, After the stoppage of the menstrual bleeding also, for a few days the patient is likely to have spotting, she will continue to have spotting even after stoppage of her menses. Now AUBE or the endometrial causes. Here basically it is the endometritis or inflammation of the endometrium that is responsible for the AUB. It could be PID, that is pelvic inflammatory disease as a whole, of which the endometrium is a part and therefore leads to AUB. Or it could be a cervical chlamydial infection that has ascended into the endometrial cavity, infected the endometrium, leading to the abnormal bleeding. Or it could be a tubercular infection of the pelvis as a whole, which has now infected the endometrium, caused endometritis, and that is what is leading to the abnormal bleeding. Now post-abortal or postpartum infection. Here nowadays post-abortal is very much relevant as medical MTP pills are very easily available over the counter. The girl, usually unmarried, she takes these MTP pills. She may even pass a few products, but there are retained products of conception. This leads to infection and endometritis, finally leading to some abnormal bleeding. So it is very important that we ask the history of medical termination of pregnancy to the patient, and as I have already said, she may feel shy as she is unmarried to give the history of taking MTP pills, but the history is very important here. Now same in postpartum infection. The lady may have delivered some 2-3 months back and then the endometritis set in for whatever reasons, lack of hygiene or any other reason, and then this endometritis leads to abnormal bleeding. AUBI or the iatrogenic causes. Here contraceptives are the main problem, hormonal and IUCDs. Now in hormonal also we will have the two types, the oral and the injectable one. In the oral ones, OC pills as they are commonly known as, these OC pills the lady may have been consuming them for quite some time, but she may forget 2 or 3 pills in the cycle and that would lead to breakthrough bleeding, or she may have taken it very irregularly or not according to the protocol, which will lead to AUB or abnormal uterine bleeding. Now injectable, the DMPA or the depomedroxyprogesterone acetate. Here after the administration of the injection, some 2 or 3 months at least, or the first 2 months maybe, the lady will keep on having irregular bleeding and then she will get amenorrheic. So initial first 2 months there will be AUB. Now IUCD, here the plain placement of the copper T inside the endometrial cavity, because of the mechanical friction the lady may have some abnormal bleeding, or the placement of the copper T itself could lead to heavy menstrual bleeding during the menses in the first 2 or 3 cycles, and that is easily treatable with non-hormonal medication. Anticoagulants, this is another important group of drugs that could lead to HMB. Aspirin, the cardiologist may have prescribed it for hypertension or hypertension with diabetes mellitus or any other condition for which the patient is at high risk of, therefore aspirin has been prescribed, and this could lead to heavy menstrual bleeding during her menstrual cycle. Warfarin is another drug which is administered to patients who have had valve replacement surgery, especially the metallic valves. So with warfarin also the patient could be likely to go in for heavy menstrual bleeding. Rivaroxaban. This is a new drug which is prescribed for patients of DVT, and if it is taken for a longer period of time or say irregularly, then she could also have some form of AUB. Now, drugs affecting the dopamine metabolism, tricyclic antidepressants and the phenothiazines, they also could land the patient into some form of abnormal uterine bleeding. Now, AUBN not otherwise specified. So, whatever other forms of AUB we get which do not fit in any other subset, they will be grouped under this AUBN. Here, myometrial hyperplasia could be one cause because the uterus is bulky, therefore, the endometrial cavity is enlarged and therefore, the heavy menstrual bleeding, or it could be AV malformations. Now, they could be congenital or they could be acquired. If it is in the acquired category, then we have to take the history of a previous DNC, that is dilatation and curettage. If the patient has undergone this surgery, then she could have acquired AV malformations. So, history taking would be important in these cases. Now, with this slide we come to an end of the differential diagnosis of the AUBs. Next lecture we will be taking the evaluation and management of AUB.